So let's jump into that now. So the MIH, that's kind of what you're all about.
Mhm.
I found you on TikTok initially and found your social media there, and I was like, oh, what's this all about? And I feel like I don't really have a good understanding of what MIH is. Like when I hear the word mobile integrated health, I kind of think of like a big picture. There's lots of people showing up in like a big team. That's
Mhm.
that's what comes to mind to me. So help me understand. Is that an accurate understanding, or like really give me the nuts and bolts of what MIH really is?
Yeah, so I always like to preface, so you'll hear a lot of times mobile integrated health, and you'll also hear community paramedicine kind of
Yeah.
used interchangeably. And the way I always like to frame it up is, so mobile integrated health is a system. So it's an umbrella system, essentially conjoining efforts of a healthcare system, bringing them together to work continuously for the care continuum of the patient. You're doing that by mobilizing your care or kind of going outside the hospital walls. And that's kind of where our community paramedics come in.
Gotta get a grip or get a hold of myself.
Welcome to Last Known Vitals. My name is John Smith, and today I am joined by Sam McGill. Sam has been in healthcare for over 10 years, starting off as a volunteer and worked her way up to becoming a critical care paramedic. She currently works in Iowa in the Southwest region and created an MIH program. I'm really excited today to learn all about what MIH means and exactly how it works. Sam, thanks for joining me today.
Hello. Hi. Yes. Thanks for having me.
Yeah, absolutely. So I'm really excited to get into MIH and learn all about it. But first, before we get into that, I just want you to tell me a little bit about the culture of what you currently work in.
Yeah. Yeah. Absolutely. So currently, I am at a critical access hospital in a very rural region of Iowa. What we do is we have our 911 team that is actually based within our hospital. And so all our paramedics are hospital employees, which kind of led me into the integration of MIH into the hospital. So yeah, I work a little bit on the truck. So 911 truck, we do all of our county EMS. And then on top of that, we do an MIH program and ran by myself for the past year, which is separate from our team, our 911 team. And yeah, we've been doing that past year, like I said, and kind of running with that. So that's essentially the general makeup. But
Cool, cool, cool. So when you guys are in the hospital, are you working like on the floor as well in the ER, or are you kind of like in your own separate world?
yeah, no. So our 911 team, so all our true traditional medics are fully integrated into the hospital as well. So we do a lot of any rapid response within the hospital. We do a lot help out with intubations, any traumas that come in. We're a part of the trauma team. We work in the ER on some of our lower call volume times and things like that. So, right, when you're on a shift, 24 or 48 shift, on the truck, you're also really integrated into the hospital and kind of inner workings of that as well.
That's awesome. You get the best of both worlds, kind of get to go play and do all the skills and have fun there. And
Yeah.
when I was on the street, I worked for a hospital-based service, and we were kind of separate. Like we had our own base that was, you know, adjacent to the landing pad actually, but we were, hospital employees, so everything was associated with them. And I would go over there and like play in the ER, and just like you just said, kind of get some intubations in there, just help out with like IVs, and just kind of have fun. It was like a playground, if you will, for a lack of better terms,
Yeah, you get all the
but
skill experience and don't have to document so much.
exactly. Yeah, that was exactly my role then. And then when I switched over to being primarily like an ER medic, that then it was different. I was doing the IVs, and they unfortunately don't let us intubate at the hospital they work at now as a medic. But it was fun. Like we were still part of the trauma team, the co teams, all that stuff, and we were really just we were able to help out in a lot of unique ways there. But one thing that you and I had talked about before, and I feel like I didn't get a good enough understanding, and I want to touch base on it real quick before we get into the MIH stuff.
Mhm.
We had talked about how you guys have RN-exempt programs, and that encompass like using an RN kind of as a paramedic in that in the pre-hospital world. We'll say it like that. Help me understand that a little bit more. What exactly is the RN exempt, and how do they like? Just talk to me about that in general.
Yeah, yeah. So I honestly did not realize that this was not a very common thing. So I guess I just always assumed being in Iowa, the RN-exempt had always kind of been around. So it's essentially a medical directed. So your medical director kind of determines, so an RN coming onto a truck or acting as a paramedic. So RN-exempt paramedic is usually what they're referred as. So this kind of all stemmed from years ago in Iowa, the staffing shortage of our 911 professionals and pre-hospital professionals. And so they came up with the solution of adding RNs availability to that as well as this being something that we can help with our volunteer side as well. So there was a lot of things that went into it, but that was kind of the general understanding was we'd be able to boost our workforce if we allowed RN exempts to come in. The procedure to do that is it varies. Like I said, it's very medically directed. So it's your medical director that's kind of determining what they need to do and fill the gaps of their education to be sufficient in the pre-hospital world. And yeah, so that's kind of what we do. We actually have a few that run on the truck with us at my current workplace, and they do a phenomenal job. I think they would all attest also to just the you just get a different lens when you go from being an RN or your education as RN and then going into the pre-hospital world. It's just very different. And so they all have their tidbits on, what I think is required as far as education goes when it comes to bridging that gap between the pre-hospital world and your normal nursing routine. But yeah, it's an interesting concept, but it helps. I will say,
Yeah.
I know a lot of agencies that take advantage of that type of exemption and helps us kind of fill the weaker spots in the workforce. So
Yeah, so I mean, so here in New Hampshire, we don't have anything like that. You have your RN, and then you have EMT, basic, advanced, and paramedic, and
hmm
you need to carry the different certifications. And a lot of my friends that are nurses are like, how do I get into it? And I was like, I don't know, and
right.
then you and I had a chance to talk a little bit, and you had mentioned this. So I guess I have the couple questions I have with that. So so there's no real standard approach to like what the education requirements are because it's medical director based.
Correct. Yep. So if you were to go to the state, request to be or submit to be RN exempt, they have a piece of paper essentially that's you have your medical director sign, giving your medical direction the authority to put in place what you will be. I will say on the paper you can put whether that RN exempt will act as paramedic, act as AEMT, act as EMT. So they designate your specific level, but I will say almost most, if not all the time, it's mostly paramedic, and maybe if it is like on the volunteer side, sometimes it's AEMT. So it really just kind of varies, like I said, agency by agency, which is pros and cons to that. But yeah,
Yeah.
it's yeah.
What exactly do they have to do to show competency? Because like obviously Airway is the big one that comes to mind, but like an RN fresh out of like school, because like I'm also a nurse, as you know.
hmm
I I feel like there's a very big gap there between what pre-hospital and being a paramedic is like compared to RN that's just kind of generalized at this point. They haven't really found a subspecialty. So like an ER nurse, I feel like that bridge would be pretty easy, a little
Yeah.
bit of airway stuff. But like, so what exactly do they have to do to get that paramedic check off and be able to go act as a medic without that education?
So I'll speak really to kind of our agency, because like I said, it
Sure,
does
sure.
vary a lot. But I
Yeah,
will say, and I think a lot of them, the RN exempts that we do have in practice, they would really attest to the fact that it's not necessarily learning is like your airway and you're very specific, what medics are kind of known for. Those type of things we can teach skill, but the
absolutely.
big thing is the foundation. So I would say, and a lot of them don't agree with this, which is okay because no one really wants to go back to school after already being done with a nursing program or paramedic
Yeah,
program. I totally understand.
yeah, for
But
sure.
like EMT school is a good EMT program can really help you build the foundations of like what we do, why we do it, why it differs from maybe what you would see in like a more controlled setting in a hospital, and
Hmm.
kind of that critical thinking that just differs a little bit. So I will say that's something that is beneficial, but not always like financially sustainable for different places.
Yeah.
Sending people to programs like that. But I will say that a lot of that foundational work is implemented into our agency during our orientation process. So they go through an orientation process, we go through all of that, and then we go through our higher level um, uh, uh, procedures like your airway. and
Sure.
a few other handful other. Again, since we're integrated into the hospital, it is pretty nice. We have a lot of access to like our surgery center. They let us come up and practice intubation and things like that, where it can get them the experience to become more proficient a little easier. Whereas, your volunteer programs, things like that, it's a little different. So yeah, it helps us being in the hospital, and getting them that experience to get on the truck independently faster and more
Yeah.
confident.
Absolutely. And that definitely makes a huge difference being right there. Do you find that it's mostly like ER nurses that are fulfilling this role?
Yes, yes,
Yeah.
and I should preface that. So it is strongly encouraged that they come from an ER role, ICU role,
Okay.
some critical care aspect to their previous experience because
Okay.
it,
That
it lays
makes me feel better. That's definitely a lot more appropriate if from my opinion anyways. And that integration and that kind of crossover is very,
yeah,
organic, just kind of comes, right? Like
yep,
it's very similar worlds, but there are some differences. And I think you hit it on the head with the EMT basic, I get it. It's the basic level, it's the entry level into the pre-hospital world, but it really does cover that foundation of what pre-hospital is all about, BLS before ALS, and that
yeah,
really gets driven home in that. So I agree with you. I think that would be beneficial if they could at least attend that level course and then kind of the integration from there.
yep.
My last question for you: do they follow like a? Do you guys have like a state protocol, or like what's the protocols that you guys all operate under?
Yeah, so we do have state protocols, but again, a lot of our protocols, so everything's based off our state protocols. So we have the state protocols, and then we write our protocols based on our different agencies. So
Oh,
some
okay.
agencies have differing interpretations, I should say, of the state protocol.
That's one way to word it.
Yeah, but yeah, yes. We do have state protocol, but our RN-exempt doesn't have anything. They fall into the paramedic scope, if that makes sense.
Okay.
Yeah,
So whatever you guys follow as a medic, the RN is going to follow that same
correct.
protocol, and then your medical director can alter that or have influence over that. Is that accurate?
Yep, yep, yep.
Okay, so that's cool. It gives you a lot of wiggle room, and especially working for the hospital, being in a small community, things like that, rural, like that integration really allows for a lot of opportunity to be expanded scope, if you will, or really cater to the needs of that community. So I love that. I think that's fantastic.
Yeah, and that's really ties in well to the ability to showcase how paramedics being integrated into the healthcare system really benefits everyone involved.
Absolutely. So let's jump into that now. So the MIH, that's kind of what you're all about.
Hmm.
I found you on TikTok initially and found your social media there, and I was like, oh, what's this all about? And I feel like I don't really have a good understanding of what MIH is. Like when I hear the word mobile integrated health, I kind of think of like a big picture. There's lots of people showing up in like a big team.
Hmm.
That's what comes to mind to me. So help me understand. Is that an accurate understanding, or like really give me the nuts and bolts of what MIH really is?
Yeah, so I think I always like to preface, so you'll hear a lot of times mobile integrated health, and you'll also hear community paramedicine kind of used
Yeah.
interchangeably. And the way I always like to frame it up is, so mobile integrated health is a system. So it's an umbrella system, essentially conjoining efforts of a healthcare system, bringing them together to work continuously for the care continuum of the patient. You're doing that by mobilizing your care or kind of going outside the hospital walls. And that's kind of where our community paramedics come in. So our community paramedics are the providers or the main kind of boots on the ground providers of this system. So they're able to work within the confines of the integrated system. And yeah, that's kind of the basis of the two coined terms you'll hear a lot. But yeah, you aren't wrong. So mobile integrated health, and I'm going to speak solely to my agency because again, just like, and I actually heard something the other day where someone was saying, once you've heard of one MIH program, you've heard of one MIH program. They have very similar foundations, but they're just so many variables that go into it because what you're doing with mobile integrated health is you're truly tying creative solutions to your community need, and you do that by utilizing the different healthcare disciplines. And then by doing that, you can kind of put everyone on the same team and provide better outcome, system efficiencies, and empowered providers. So
So along with the paramedics, what other agencies are involved in this MIH?
yeah, so for ours specifically, our MIH clinicians are involved in our care team. So with our care team, we have I mean, your typical, your whether it's your specialty primary care nurses, the ER, maybe the ER providers involved as well, all kind of dependent on the patient's current care pathway, care continuum, where they're at, hospitalist, things like that. So it's really just bringing everyone together and kind of on the same page to make sure we're all kind of pushing for the same goals for this particular patient.
Do you think something like that would work well in a big city?
Yes, I do. I think it comes with its different challenges, and I think everywhere comes with its different challenges. I'm in a rural setting, and like I said, we're kind of a unicorn a little bit with how regionalized and integrated we already were before we implemented MIH. It was almost like we were able to insert the community paramedic as a kind of final piece of the puzzle. Well, I shouldn't say that. It was a long program development, but it worked very smoothly because that was kind of our entire thought process, and we already that's what the goals we were already moving towards anyway as a system. So in the metro aspect, it can look a lot different. I will say, so there's a lot of great fire-based EMS, MIH programs or community paramedic programs. You'll hear a lot, and their goals are very similar. Again, they're looking at community need and finding solutions to provide that need to ultimately, whether it's reduced call volumes, high utilizers, a risk of readmission, things like that. They just do it in a little bit of a different way because they aren't fully integrated into a major hospital. Obviously, health data exchange, things like that. And we all are very aware of how hard that is to kind of find that gap and bridge that. So it is a little harder, but they do find creative solutions. And you'll see that a lot of times in the metro. That's usually what the programs will look like. But you do also still have your big hospitals kind of using this type of thing. And I will say a lot of it is with that high ER utilization. We all have seen those big hospitals and how kind of crazy those ERs can be. And that's what they want to do, is be able to still provide high quality care. Just we need
Reduce
to
the volume and
it.
reduce the
Yes,
numbers.
correct. And
Yeah.
so
So
MIH comes into play with that.
so do you guys get connected with people that are outside your hospital? Is there, or is it strictly like patients that, somehow are connected within your hospital program?
Yeah, so no, well, 50-50. Most of
Okay.
the time it is, and you'll hear me say that a lot. It is not there is no tried and true of system, and I will say this is a very big pro of MIH, is that it is so adaptable and flexible, which again does come with its cons of
Sure.
trying to streamline things. But I will say, yes, so it's based on community. So even if this patient goes to the neighboring county hospital, but what happens is they come to RER for whatever XYZ, we still see them and treat them and add them to a care plan within our system. And that's something I kind of really strive for, because it's based on community, not necessarily just our current hospital,
Yeah.
patient population. But I will say it's easier to get our patient referrals through an internal force. So we get
Sure.
them based off of our care coordination team, which kind of works within the hospital walls for resource connection, ensuring clear communication with patients, things like that. So we
Is
get
it
that from them through we have an ER care coordinator, and then we have what you would think of as like kind of like our discharge planners, but like kind of our med surge care coordinators as well. So
I was just going to ask you, like, is it like a social worker or something like that that helps coordinate with you guys, saying, "Hey, I think this would be a good patient to follow up with," and stuff like that?
yes, yes,
Yeah.
and it's very goal outcome based, so we wanna make sure that we're, getting patient referrals, that there's something there that we're able to kind of attack and provide, some sort of outcome or better outcome for the patient. Yep.
So walk me through a day. Like when you get to work, you're on the MIH team for the day. What exactly does that look like? What are you doing in the community for these patients? Like what is your actual role?
Yeah, so usually I'll have a handful of visits, during the day, and these visits usually last from anywhere from 20 minutes to some of the more higher acuity ones, 45 to 50. So those are usually how I start off my days. We go through our referrals in the mornings. So we look at any new referrals that come in. They come in on a daily basis. And yeah, I have kind of an internal criteria index for our program. Something about MIH too is once you implement these type of programs, you'll realize your caseload is going to far outweigh any of your current piloting
Absolutely.
workforce. So you
Build it
really
and they will
gotta
come.
yes, and that which is awesome to see, but it is a little you gotta get creative on how you are prioritizing your patients and making sure
Right.
that the ones in the highest need are getting the quickest help and the highest risk and things like that, which is sometimes a little it takes some trial and error to figure that criteria out because again, there's a lot of foundational work that's already been done with like LACE indexes and things like that. But trying to apply that in kind of a new format like MIH can take some trial and erroring. So anyone that is starting a program, trust me, I hear you. That is a very hard portion to start with. But anyway, sorry, I got off.
No, no, I appreciate that because like it's another component to this of like how do you prioritize like who gets
Yeah.
first dibs if you will or like you only have a few people available to do this program like and
Yep.
there's a lot of need so
Mhm.
once you open that can of worms it's like oh my god like I can only imagine how overwhelming that must feel.
Yes, yes,
But yeah,
and
so carry on though. So
yeah,
you
so
show up to
yeah,
these
we can
patients'
touch that
houses.
later.
Yeah,
There is a good portion of detail on that. Anyway, so yeah, go through our referrals. I go on my visits. My visits really look like we try to go through like our initial visits are a lot longer, so we'll go through like kind of an intake process and talk with the patient, go through a full med reconciliation, go through a housing assessment if there's any sort of fall risk, safety risk or assumption from our discharge planners that needs to be addressed. We'll go through all of that. So our intakes can be a little longer than normally our follow-up visits. And then yeah, we'll go through what happens usually is we'll go to these visits and there's a lot of follow-up work to do thereafter. So then that's kind of the last portion of my day is then making sure we're connecting all the dots, talking to all the right providers. We have, like I said, fully integrated into our system. So we have direct access to whether it's maybe we need to go through like a clinical pharmacy review with these patients so we can get connected to that team, or we need to discuss maybe pushing a procedure up quicker. Just last week, I had a patient that we had to push them up. They had a thoracentesis scheduled out within like maybe like it was probably 20 to 30 days, and he needed it tomorrow.
right.
So we had to go through that work, and right once we visited, we he and this is also an important thing to discuss. You have to be very fluid on your days. So my typical day doesn't look like my next typical day because this stuff happens a lot. Where you go visit these patients, you see a immediate or subacute, I should say, intervention that needs to be happening. So you kind of shift gears and have to kind of go then and make sure that that is solved before you carry on. So
Yeah. And
my day
that's
is
so
yeah.
cool though
Mhm.
because like you guys, there was a very high potential for an acute emergency to occur with this
Correct.
patient
Yes.
any minute, any day, any minute and clearly wasn't going to make it the length of, for a scheduled procedure. So the fact that you guys were just there kind of following up doing what you're doing like
Mhm.
really prevented that. So like that's such a cool case to reference and
Yes.
really kind of help sell this program.
And it really shows too, just I mean, when you come in between, we showed up at the right time, the right place, and we're able to get him to the appropriate space versus having to have him come in an emergent manner, which would have ended up happening into our ER. And right, things had to kind of then they get a lot more expensive. They get a lot more, it's a different world. Whereas if we can do this in a routine manner, it's better for the patient, it's better for the hospital, and it's really better for us as well if we can
Yeah.
try to intervene things like this and prove the worth and value of providers like us. So
Absolutely. No, and that's clearly an obvious patient that I would
yeah.
present to like, here you go. Like, hey, this is fantastic. You know what I
Mhm.
mean? That's a
I didn't
cool
think about it
story.
actually. Yeah, it just popped up in my head. I'm like, yeah, that's a perfect. Um,
Absolutely.
yeah.
Because otherwise, like we said, like that patient would have shown up in the ER probably in a much worse state than when you found him.
Hmm.
And who knows what could have happened. Like that could be the difference between somebody living and dying. Like not to get like dramatic, but like legitimately that could be the difference,
Yep. Yep.
So
Absolutely. Absolutely.
that's awesome. That's cool. So here in New Hampshire, where I live, we have something called the VNA, and it's the Visiting Nurses Association.
Hmm.
And, it's kind of similar to what you just described. They get hooked up, whether it be through the social work at the hospital discharge. And there's different ways that you can get hooked up with these different services. And I'm not overly educated, and I'll be very honest,
Yep.
um, that's kind of what my wife does actually. She's a nurse care manager. She does it over the phone and like
Yes.
coordinates a lot of their healthcare there. And I'm
Hmm.
sure you're familiar with them.
Yep.
So what would how do you guys differ from the VNA and what the V let me kind of preface a little bit. The VNA here in New Hampshire they go out, they'll visit with, like I said, newly discharged patients, things like that, and they'll follow up with wounds or ostomy care, or, all these different things that a lot of patients don't really know how to manage well on their own. And they
Mhm.
help bridge those gaps. And like you said, kind of the med recs and dealing with pharmacies and in a house scan and making sure safety and all these different components. So that's kind of what the VNA does here in New Hampshire. Is that sounds similar to what you guys are
Mhm.
doing, and it doesn't really sound like there's many differences. From what I just described, are there really any big differences, or do you guys have visiting nurses like that in Iowa?
We don't have that particular position in Iowa. Well, I shouldn't say in the entire state of Iowa, but nothing that I've come in contact with. I
Okay.
will say it is similar though, and I want to preface. So MIH isn't designated strictly to EMS. There is a multitude of programs that do utilize nurse practitioners, nurses, EMTs, rad tech, anyone. Okay, so yes, I should have prefaced. So VNA probably would fall under the MIH kind of realm or column, you should say, in healthcare, and it's right, very similar probably to what
Yeah.
we do. I'm not too familiar with it. The big thing with our current programs, I I think my personal goal is to champion the paramedic within these roles because of our unique background and our unique the way that we already kind of hold ourselves within the vulnerability of patients' homes and things like that, and also just right progressing our profession. So it probably holds similar foundational values to what like a community paramedic program would look like, and yeah.
Yeah, no, it definitely sounds very similar. And where you're saying like you guys don't have anything that comes to mind with the nurses. Maybe like this is the exact same thing.
Mhm.
It's just utilizing paramedics finally, and like realizing like, hey, we're more than just pre-hospital. Like we can do more than that acute medicine.
Mhm.
Now, with that being said, though, in going through nursing school and really kind of branching my own education, there is a difference between pre-hospital acute care and then that subacute, that long term, the follow-up, all that stuff. What kind of education are you guys doing to kind of bridge that gap?
Yeah. So specifically for our program, we were able to, like I said, I had access to every specialty of a healthcare system. So during our program development, I was able to kind of dive deep into the more comprehensive review of pharmacology and go through with our pharmacists, different, what a different med list would look like and, what to look out for and things that, just different things that you don't really necessarily prioritize when you're going through 911 programs or paramedicine programs. So pharmaceutical, we went through like chronic disease management, but it was all very attuned to like our certain system. So there IBSC has a certification or board certified test that you can take for community paramedicine. Kind of runs you through the foundational work. And so that's obviously recommended for anyone that wants to kind of make this jump because it does help you turn your acute skill into a more comprehensive skill set. Yeah, that I will say I think a lot of people so when you look at like your fire-based EMS systems, I think they lean a lot more on your outside like IBSC certification testing to ready their paramedics. But you made a good point. This will always require additional education. You cannot just throw a paramedic in and say, okay, go make it happen. Start reducing ER utilization and
Right.
readmission and good luck. That does not work. And you will find, and I've found a lot of times people like to show me the MIH graveyard and all these programs that did not work because they tried to kind of do that, where they were saying, oh, right, okay, we have paramedics and we have access to the community. Let's go just start looking at people. It takes a lot of strategy, a lot of integration, a lot of development to make a program like this sustain with just the multitude of kind of struggles or conflicts you're going to run into with like funding, legality, liability, things like that. So it does take a lot, and not to get more into the policy, just educational wise too. So, right, if you want to be competent and do something that's going to actually provide a positive outcome for patients, you do have to gain that additional education as a paramedic.
Right. To run a successful program, there's a lot of logistics that go into it that I imagine, a lot of things are, I wouldn't say overlooked, but probably not thought of, or,
Yeah,
you don't realize it until you're kind of in it. And, the education is a big component as well, like we just said, and I think like being attached to the hospital probably makes a significant difference for
yeah,
seeing a program like this be successful, right? Like you have people behind you that are championing this, and
Yeah.
there's a benefit not only to the patient but also to that hospital in reducing the number of people returning and all that stuff. So like,
Mhm.
I could see why it may be challenging, or more challenging, if you will, for that private EMS service to do, an MIH. I'm not saying it can't be done by any means, especially what the hell do I know,
Right.
but I could see why it would be a little bit more challenging.
Yeah, and I will say, I think a lot of, like, your fire-based EMS, so, like, your more public systems, they do a lot on, community output and outcome, community health need assessments, community resilience. They are really looking at the whole picture, and successful ones do a really, really good job at that. They integrate social workers into, like, mobile crisis units and things like that. Our mobile crisis units have existed for a multitude of years. They fall under that MIH, structure,
Hmm.
if you will. And so you'll see a lot of community paramedicine programs start to dip their toes into mobile crisis units and have, let's say a law enforcement officer, a paramedic, and a social worker going out on these behavioral calls because maybe they have a mental health crisis within their system. And so, like, yes, like I said, it's a very variable, but ultimately, yeah, you're finding what your community needs, and that will speak volumes to, maybe we're never gonna find this money pile that we're gonna be able to take from and say, we're a big profit generating program, and I would not start your proposal off that way and promise anything like that because you won't get there. But that's not the point. And once you kind of get into it, you'll realize there are a multitude of programs that are revenue preserving, whether it comes to your city entity, your county entity, your hospital. So whether you're private, you're public, whatever it is, at the end of the day, we're providing benefit to patient outcome, efficient systems, and progressing a workforce. And once you kind of tie it up like that, you can then run with it. And I think you're on a stronger foundation than if you're going to say, like, okay, well, if you give us this grant for, X amount of money and we'll make it happen. Sure, you can make that happen, but then they're going to be expecting the same output, and
Yeah.
without any sort of revenue generation, it's going to fall flat. So you really got to build your business model to make sure that it sustains.
Yeah, it seems like it's a little bit more on the preventative side. Like, hey, you
Yes.
can cover the cost of the today's work, maybe $500,000 or something, compared
Yeah,
to like this person that's going to come in the hospital and have a $60,000 bill that you're never going to see a dime for.
exactly.
Which
Yes.
one would you prefer? So it's a hard selling point of like spend money to prevent losing money, but I can definitely see how that would be challenging to be like, we maybe can't generate a whole lot of money from this, but it's going to save you in the
Yes.
long run, and really being able to sell that. Now, is there a way that like you can recoup cost for this? Is it billable? How does that work?
Yeah, so that can vary by state. So currently in Iowa, there is no definition within our current legislature that defines community paramedicine, mobile integrated health. That is something that I very much am passionate about and working forward towards. But there are states that do. So especially like on the East Coast, there's a lot more progress, I'd say, when it comes to those type of codes and the billable aspect. But it's, again, it's not sustaining their entire budget of their program. Again, it's right, it's the business model you're going to be looking at. Now, I will say there's a lot of places that contract with insurance companies and, right, your ACOs, that the ultimate goal is to prevent, right, your costly readmissions, high ER utilization or unnecessary ER utilization, things like that. So there are creative solutions around it. You just got to think outside the box a little bit and go outside of like your typical, like, especially as like 911 system, like your transport codes. You're never gonna get to that point. But there are creative solutions. And then as we continue to show our value and worth, we're going to be able to then push for more stronger legislature, which is then going to push into your Medicare, Medicaid, and kind of all the revenue generating streams. So yeah.
Right.
So
And
no,
yeah,
it's a long answer short. No, currently there isn't a solid countrywide foundation there, but I think we're getting there. There's a lot of progress that's happened in the past few years because these different programs have sustained otherwise. So
Right. And again, it's such a infant, program across
Mhm.
the country, of course. And, I think it's going to take some time to really show its value and things like that, which is
Yep.
obviously there, but it's
Yeah.
going to take some time for everything to kind of catch up to it.
Yeah.
And in New Hampshire, like I said, we have that VNA service, but from my understanding, and I know, like you said, like the fire services and stuff like that, like we're starting to really see a lot of that community outreach and community
Yep.
paramedicine kind of evolve. I'm not overly familiar with too many programs locally. I've been hearing like whispers, and I'm sure there are some already working, and I just don't know. It's a part of my ignorance.
Hmm.
But I know, like from the VNA standpoint, they're under the Medicare, Medicaid, I believe, I think, anyways. Again, speaking with some ignorance, but
Hmm.
they're able to bill and stuff like that because I know a lot of their paperwork is for that compliance. I think in time, if a program like what you're doing with the MIH could really fall under a similar model, then you could probably sell it a lot more, and you would have a lot more opportunity to see new MIH programs really, pop up and evolve. And again, it's just going to benefit the community. So like, why not?
Yes, exactly. And unfortunately, speaking to those organizations that are kind of going to push that, you have to really frame it up as the value. You're looking at the
Yeah,
value, and we're collecting right now is very much a data heavy period of because we have to show that value in order to then push for right then being reimbursed for it. Unfortunately, that's just how it works.
it's all about the money. Like,
But I will say also, there's a lot of value to show the indirect cost savings too. There are a lot of programs, and I think people get very hung up on the funding and the revenue streams and things like that, which I totally understand. But I think it's because they're looking at it from like how we get billed or how we get our compensation from like our transport billing codes, things like that in 911. I'm not saying it will never look like that. I'm just saying right now we're going to have to get creative and look at like our indirect cost savings. So it's the solution isn't like, hey, we're providing a bunch of generating a bunch of revenue for you. What we're doing is preserving revenue for you. So the solution is still there. It just you're shifting how essentially. That's
sure.
because and I will say because and that's on like the hospital side if you're integrated in the hospital or you're a county city type of program. What they do is that's their bread and butter is we save you money, whether it's because of the high 911 call volume that they have, or things like that. It's like I said, it's saving them ultimately money, unfortunately, because my thing and my priority, obviously, and everyone's that does these type of programs is your patient and
Yeah,
providing the best care for them that we can. And that's always our number one priority. But unfortunately, that's not going to carry a substantial amount of weight when we talk about sustainability,
yeah.
which just sucks. But that's just the world we live in, and that's fine. And we just have to get creative and find our way to keep building and growing.
For sure. And that's just the reality of it. Like there's a desire to want to be able to help the world. Like that.
Yeah.
I mean, if you're just a decent person, you should have that ambition to want to do good for other people, right? But obviously there's a cost to everything, and it is business at the end of the day as well. So, you got to find that balance, and that's obviously what you guys are trying to accomplish, and I love it. That's good stuff. So, do you think that, or how do I word this? Is there a lot of interest from medics in your area to get involved in programs like this?
Um, 50-50. So, yes and no. I think it's more the ignorance of not knowing what it is. So, the
Sure.
more people start to learn about what it is and what we do and how we're doing it, the traction starts to pick up a lot more. Initially, no, 911 medics are adrenaline junkies. They, love the high of the risk and yeah,
But
you
hold
know,
on. But let me stop you right there though, because like we're all the adrenaline junkies. Sure, sure, sure. I'll agree to that. But every one of us is burnt out as could be. You know what I
exactly
mean? So like there's that
correct.
side of it too. So I feel like it offers this whole new world to kind of approach medicine from. And
Yeah,
and like I don't know. I feel like it would excite me to have a new opportunity to get out of that 911, complete just burnt out mindset, and like, oh, there's something new I can do with this experience and my license. So I don't know. I feel like that would be a great opportunity.
I agree. And I also feel that eventually people get there. It's hard to the identity it's an identity shift. It's when we
Sure.
talk about integrating community paramedicine into our 911 structure, it's just hard. Change is hard, but I will say we're already doing the work. We're already going to these calls. Right, 80%, I'm going to say just overgeneralizing, but 80% we have the low acuity grandma fell, we're picking her
Absolutely.
up. That
Right.
is a lot of our job. So we're doing it already. We're going to these calls already. What community paramedicine foundations or concepts can do for our profession is actually allow us to then do something about these type of calls. So the seventh time that Mary Jo called us that because she slipped out of her chair, but we can't do anything about it. You hear that our hands are tied.
Right.
If we were more integrated into our healthcare system, if we were more integrated into our care teams, we would be able to kind of intervene quicker. And we had access to referral pathways and things where we could, hey, this patient, you haven't seen her in the ER yet 'cause she keeps signing a refusal, but she needs home health or she needs some sort of assessment for gait or whatever it may be, physical therapy, OT, whatever that, yeah, certain patient needs, you're able to actually then go connect them to that. That would be my dream. If we could just get everyone on board and we could make community paramedicine integrated into what we already do and develop appropriate scheduling and workforce and everything around that, that would be awesome. Unfortunately, I think to get buy-in from our current workforce, it's going to have to be shown separately and then moved maybe, and some of those concepts may be moved into what we do on the truck and on a daily basis. But so yes, I think as we kind of continue to, I will just speak specifically to our program. Our medics at first were very apprehensive of, and they weren't even, so ours is separated. So our MIH program is outside of what we do on 911. So none of our 911 medics are having to do any of this work, which is kind of on purpose. I wanted to set it up that way because I wanted to show it before, you're going to say, hey, you have to do this now. That's not going to work.
Nobody's gonna
Uh,
be happy with that. Even if
right.
it's cool or good or no one's gonna be
No
happy
one's going
being
to like
told
that.
you have to do this, right?
Yeah. Um, yes. You're juggling a lot of different balls when you're trying to do something like this because it's a lot of change on the system side. There's a lot of change on the personal side. It's a lot, but it is doable. And so as they're kind of watching how this all is playing out and listening to the different outcomes that we've had and kind of success stories we've had, I will say that their ears are perked a little more. They're definitely a little more interested and they're like, okay, tell me more about that. And whereas first it was like, I don't want to hear about your home health.
Right.
They're very supportive. But yes, it's hard to kind of idealize that. Not everyone's going to think similarly. So I do think it's gaining a lot more traction. And I will say just the curiosity that I've found on like the social media aspect's been very interesting just from different medics around the country kind of inquiring about it. It's been interesting. It's been your combat medics and your wilderness medics that like do things completely very creatively versus just like your typical traditional 911 truck medic. And I think it's because they have the mindset of like creative solution. And that's kind of the way I look at it is this is really just another creative solution to the issue that we're seeing, whether it be your burnout or your fragmented care pathways or whatever. It is a true solution.
Yeah, it sounds like you guys are just a real, voice for the patient. You're a great
Yeah.
advocate, and it's like we have a lot of experience with the 911, that acute medicine, but it's really evolving now, and I think it's going to be fantastic in the future where this truly evolves to. I think the MIH definitely gives an opportunity as well to those burnt out medics. Like,
Yeah.
hey, you don't have to hang up your shirt just yet. What else are you going to go do? Let's be honest, because that's where I found myself in.
And that's yeah, and I think even with the burnout aspect, I have at first I was like, yeah, you can it's it doesn't have to be we leave in order to reduce burnout. It's I think a lot of the concepts and structure of community paramedicine being if we progressed our profession as a whole, I think it would reduce burnout. If we like I was saying, like if we allowed, these different type of uh solutions that we can provide, not just like your skill oriented solutions, but your more socioeconomic oriented solutions. If we could start providing those on the trucks and doing those type of things, I do believe it would help our burnout, our on with a bunch of other things. But for the most part, I think that's a solution where I hate to silo it too hard away from 911 or our current majority workforce because
Mhm.
I do want paramedics to champion it because like I was saying earlier, I mean, someone's going to be championing this. The concept of MIH isn't really necessarily new. It's more or less the idea of paramedics championing it is kind of new. And that's where I want to hold on to that momentum because it would be an awesome thing for the profession that currently we're all trying to figure out, okay, where are we going from here? Because what we're currently doing is not working. So
Right. Yeah, no, and I think it's you guys are doing some really good work out there.
yeah.
I really do. I've been it's been exciting to learn about this and talk with you
Yeah.
finally. So Sam, I just want to say thank you so much for coming on here today. I want to give a shout out to your own social media stuff because I want to make sure people are hearing your message. You're on TikTok as Medic McGill.
Yep.
You're also on Instagram. Is that? Do you have any other social platforms or anything like that you want to talk about or plug?
Nope. Currently, those are keeping me plenty busy.
Absolutely, absolutely. And now I want to end on this final thing. And you know, I'd heard you say this before, and I hope you got it right off the cuff. Your three P's for an MIH program. What do you need?
We need a paramedic, a purpose, and a patient.
I love it. I love it. I think that's just such a cool saying. Like I said, I'm really excited to see where you evolve this program to and where the country even evolves with MIH. I think it's definitely part of the future for EMS and for patient care as a whole. So again, Sam, thank you so much for joining me, and we will definitely talk soon.
Absolutely. Thanks for having me.
All right, well, take care.